In this presentation, we feature Barry Jennings discussing myofascial release. Barry will be discussing several different styles of myofascial release and how they can help you increase your success in treating difficult conditions. He will show some incredible before and after pictures, including one who miraculously survived a skydiving accident, and which Barry was one of Barry's toughest cases. I'd like to introduce you to our presenter, Barry Jennings. Since 1986, Barry Jennings has taught over 4,500 doctors, chiropractors, physios, and massage therapists an effective and highly successful brand of myofascial release. His unique style incorporates all different styles of fascial work into an effective and successful modality. Jennings' myofascial release seminars provide effective, easy-to-use myofascial techniques through hands-on workshops, DVDs, and published manuals. Barry, welcome to the World Massage Conference. It's wonderful to have you presenting.
Hey, thanks, guys. I really appreciate that. And for all you guys who are massage therapists and practitioners, congratulate yourselves. It was a massage therapist I got together to provide a world conference for people to talk about how to help people. And it's just a humbling honor to be here. And thanks very much. And hopefully we can have some questions and move forward on, how do we help our clients? How do we help our clients? Thank you very much, Scott.
Well, thank you very much for being here, Barry. Are you ready to start with your presentation?
Let's go. So let's go to the first slide.
Okay.
After my my propaganda, my logo, let's move from that.
Okay. We're good to go.
So fascia. So fascia is the place to look for the cause of disease and the place to begin. In no way was myofascial release developed just last week or a week before. It has been going on for a long, long time. And I want to really give credence to those osteopaths in the United States and in Europe and the people who have done the Rolf movement because they really have supported all of us in helping teach people how to do some direct fascia work and how to enable clients to maybe see a little bit more pain resolution. And it's an awesome style work. Just want to use this slide just to mention that it's gone on for a long time, and we continue to move the work forward. Let's go on to the next slide. So I'm at presentation outline. What we're going to talk about today is what is myofascial release. How does myofascial release work? What is fascia? Everyone talks about fascia. What is it? I'm going to show you some pictures on that describe and show fascia. Next thing I'm going to look at is some before and after pictures. And these are some phenomenal changes that anybody can do. They have changed clients' lives, and they have changed certainly me as a therapist in making me more humble about this work and how fascia work can help. Having said that, in no way do I believe that myofascial release is a better technique than craniosacral work that does Swedish work, Traeger work. It's another tool for people to add on. Nothing works. There is not one technique that only works for everybody. It simply isn't the case. It's a tool that you guys can add on. And then at the end of the lecture, we're going to have some time for questions and answers. Scott, I'm going to move on to the next slide. So, what is myofascial release? In its basic terms, it's manual therapy. It's hands-on therapy used to improve the function and mobility of the fascia. That's its intent. Its intent is to work directly with this tissue called connective tissue or fascia. What's interesting about the work, and when I travel around teaching in various schools, is that the techniques really look basically similar to a regular Swedish style work. What changes, though, and what seems to have its intent and focus in on the fascia, is that we move slowly into the area, into the muscle, with little or no lubricant. And that is that it allows us to engage that fascia in order to help it release, soften, become more mobile. So Scott, I'm gonna move on to the next slide.
Barry,
yes, sir?
Before we move on, is it possible for me to get you just to project your voice a little bit more for us?
I sure can. How's that?
That's great.
Sorry about that. Most of the time, at least in my household, people tell me to be quiet a lot, so I guess I just have to change that up.
Perfect.
And I have people in the seminar right here actually laughing about that, so I will actually try to sound louder. All right, so let's move on to the next slide. So Scott, what I have right now is myofascial release styles. There is two main fundamental styles in regards to MFR, and that's the short term. Direct style and indirect. So what's direct? Well, what we're trying to find is the area of restriction. The site where there is, say, an adhesion, matting down of the tissue, whatever you would like to call that. What we do with that is through the use of our hands, elbows, fingertips, we glide through that area of restriction, or we ask for movement. So what's movement? It would simply be the client breathing, stretching. Keep in mind the techniques are done very slowly. It just seems to increase the engagement and the success of the technique. On the opposite end, in the opposite spectrum, in regards to myofascial release, there's something called direct, or I should say indirect. Indirect is also called static. Well, what's that? Well, we're finding the same area restriction. We're working on the same tissue. But instead of gliding through that area, we generally, in a cross-hand pattern, and there's going to be a slide coming up to show that, we engage that fascia, we separate our hands gently, and then we wait for it to release. 90 seconds, some cases up to 5 minutes. Once again, it's a cross-hand pattern. Who would you use this for? Acute conditions. And the other one, and I'm sure everyone's going to start nodding with this, fibromyalgia. Fibromyalgia is a very complex condition. Static work or indirect myofascial release, very successful. Very successful. Now let's move on to let's move on to the next picture. Let's get some color into this show. So what's fascia? Well, if we look at the top slide, it's the tissue that surrounds all the muscles, tendons, ligaments, and bones. There is no beginning, there is no end. If we look at that top slide, that red filament type of structure, indeed, that's the muscle fibers. If you look closely enough, you can see this white filmy material. That's the fascia. Here's another example of fascia. If you take, for example, a chicken breast, and you take the skin off, it's that white filmy tissue that is underneath. That's not fat, that's actually a layer of fascial tissue. How powerful? 2,000 pounds per square inch of tensile force. That's a pretty amazing structure. Some say that it's the same tensile strength as a radio tire. Often I've made kind of a joke saying maybe not a Firestone radio tire, but I'm not sure if they're one of our endorsements, so I'll just move on from that. Point being, very powerful. You cannot go in there and overpower this tissue via massage therapy. And that's why the techniques over the last 5-10 years have begun to become slower, softer, and move with the fascial tissue. What does it do? What's fascia do? It controls our posture. It can control our movement. If we look at that second slide, the one below where the fascia is, you see a green webbing-like material. Now, fascia is not green unless there's some major disease process happening. What I'm trying to show and indicate is it is a webbing that has no beginning, has no end. An amazing book that you can get probably at Amazon.com. It's called The Endless Web. It's a book written by a couple Rolfers. First editor and writer, his name is Schultz, and it really talks about this webbing, and it's an amazing title. For example, if you look down at that right part of that hip, and let's say you were able to grab a hold of that green-like webbing and twist it, can you see how it may very well reflect or begin to pull the opposite shoulder or the neck? And this is what we talk about and try to investigate and treat in regards to myofascial release. It's a whole body picture in regards to conditions, in regards to injuries, and in regards to pain. So let's move on. Let's move on to the next slide. So fascial anatomy. Fascial anatomy. So what is that? Well, if we look at that first slide under fascial anatomy, we can see patterns. We can see horizontal lines, and we can see vertical lines. So there is a pattern within the fascial system. It surrounds and connects the entire body and systems, including the organs. And this is a really important point. In regards to a car accident, it is highly probable that injury to the actual viscera can be more so than actual even injury to the muscle. Well, why would that be? That can be because there's more of a water or viscous content to the organs. So if I was to take two balloons, one I would fill up with 80 to 95% water, let's say 95% water. The other one I only fill up with about 20% water and put some type of solid substance into it. If I take each of those balloons and I throw them up against the wall, the one with the most water is more than likely going to burst. Same thing with the organs. Not that the organs are going to burst, but what we're seem to be finding is that the impact of the organs is something that we haven't looked at enough. Some of these chronic injuries that are not getting resolved, mid-thoracic pain, for example, could be indicative of something happening to the viscera. So fascial tension, if you go to the last point on the slide, fascial tension and strain can affect distal structures. So how an injury to, say, the ankles or the knees over time can be reflected into, for example, headaches. So what we're trying to do in regards to myofascial release is go, yeah, they have headaches. Is there something else happening in the body? Is there some type of imbalance? Are the hips rotated? Is there problems with the knees? Is there genu varis, genu valgus? And look at the whole structure. Once we started doing that, and certainly once I started doing that as a therapist, I became less frustrated. Pretty tough. You go to school, at least up here in Canada, 2 years, 2,200 hours, come out of school, people come in, they have a condition, you do what you were taught, doesn't work. Okay, maybe I'm not a very good therapist. It's not the case. What's happening is that there may be an injury someplace else, and hence the journey into fascia work. And I'd like to really thank some of the researchers, including, I believe his name is Robert Schleip, the Fascia Congress, for doing some amazing work in supporting us as massage therapists. We should be very proud that we have people now that go, okay, we do have the testing, we do have the proof about what's going on. So I'd like to move on to the next slide, if that's okay. So trauma to the fascia. What happens then? Well, according to some of the researchers, the tissue becomes excessively tight. It dehydrates a significant amount, for example, 30 to 40% according to these researchers. What's that mean? Well, there's an increase and an impingement, I should say, on circulation. When there's an impingement on the circulation, then we're going to see a decrease in healing. That kind of makes sense to all of us. What else do we see? Clinically, we see a decrease in range of motion. The person can't move. Whether it be the hips, shoulders, posture imbalances, significant posture imbalances, protracted shoulders, anterior rotation of the hips, genu varis and valgus. What do we see clinically? In other words, why do people walk into our clinical offices? It's because of one thing, and that's pain. Let's take a look at those two slides. So we see the healthy tissue and the traumatized tissue. What I want the listeners to take a look at is how disorganized that right slide is. If the tissue, the connective tissue, is not organized, two things are going to happen. One, it's not going to move properly. It's going to be tight and restricted. Second, there is going to be a significant impingement upon the circulation, and things are simply not going to heal. It's also why we continue to get these chronic, recurring injuries. The headaches that people get 2-3 times a week. The athlete that goes out, starts running again, and bang, the hamstrings fire up. It's usually due to some type of fascial dysfunction. And that's why, by adding, say, myofascial release to your clinical repertoire, you can get increased changes. That's the reason why I did it. You know, when I first started my practice, I took one myofascial release course. I went, oh, well, let's try it. Let's see if it helps. And it did seem to help. So I started doing more. I made the work respond for me. In other words, I took the courses and went, well, let's just see if it works. And it did help. Just like someone who, say, needs cranial work or other styles of work. Continue on your path and find out what's going to work for you. Scott, let's move on. Let's move on to the next slide. I'm really excited about getting into some of these before and after shots regards to the fascia. But let's just talk about this fascia web again. Once again, sorry about the green nylon kind of situation there. But really, when I'm working with people in my courses and we're relaying information back and forth, which is how I like to teach, you know, the fascia is like a webbing, and unlike muscle, fascia really doesn't have a beginning, and it really doesn't have an end. For those of you that maybe weren't that great in anatomy, and I think I might have to put my hand up a little bit, it's easy to work with. What we're trying to do is feel the layers upon layers upon layers of fascia and see if we can get a change. It's continuous. A tear or pull in one area affects the whole structure. That's why doing a visual posture assessment for individuals that continue to have chronic pain, it's a good clinical maneuver. Maybe there's something that is happening. What Rolf used to say, and she was really a gift, she said, if you think you know where it is, it ain't. She meant that that site of pain may be distracting us from someplace else where the problem is. Hence the world of fascia. Scott, I'm going to move on to the next picture. I really like this slide. You can begin to envision that white filming material, that fascial tissue, and how an injury in one site can reflect and begin to cause the so-called chief complaint in another area. And if you can envision a webbing within a webbing within a webbing, it really helps to now begin to understand a little bit on what fascia is doing and how it responds, and how to adjust and apply your clinical techniques. Scott, I'm going to move on to the next picture. Once again, I want to support the Fascial Research Congress 2007. Mechanoreceptors, it really does behave like a sponge. When we apply mechanical pressure, aka our hands, the fascia begins to slowly hydrate. But what's that mean? What's that mean as a therapist? Well, we can effectively change this muscle fascial tissue. Each treatment is going to improve the results. So the client, after the first, second, or third treatment, is going to see a continuation on an improvement on function and a decrease in pain. The treatments are going to hold. They're going to last longer. What I tell people in my seminars, they just don't do myofascial release. Do a few of those techniques. Do some of these techniques I taught you in the seminar, and then follow up with your great work, whether it be some Swedish maneuvers or other. It builds upon your work, and that's what all training and all workshops should do. They should support the therapist in continuing on and improving their knowledge. So I'm going to move on to the next slide here. How will MFR help me? As I just mentioned, it's a tool, a new tool to help you. It can increase success treating some really complicated and tough conditions. And probably one of the most important is that it reduces strain on your body so you can survive as a therapist. It's going to help build your clinic. Scott, I'd like to move on fairly quickly here because I know our time is starting to move. So I'm on to the techniques, Will. I just want to move really quickly down to the last part, which is the biggest changes in posture. And this is probably fundamentally the biggest thing and the most amazing result that I have found with the fascia work. So Scott, I have now moved to, and if you can, to the first before and after picture. Now what this is actually a client. This is my first client that I took through posture realignment, also called structural integration. I went down, I took the training, I went, okay, great training, not sure if it's going to work. Talked to a client, got her consent to take some pictures, and I said, let's try this. If you take a look at that first slide, what do you think she was suffering from? If you said low back pain, headaches, you're correct. And here's after doing the posture realignment. From frankly a person that really didn't have that much experience. I indeed was shocked, and so was she. What a decrease in pain. What an amazing work, myofascial release. And Scott, if we can move, and then we're going to move on to the questions and answers, which is extremely important. Let's move to that last slide. And Scott mentioned about one of the more horrific cases, and I've probably treated 10,000 people. This individual came in. She was into extreme sports. She had a master's at Dalhousie University in kinesiology, jumped out of an airplane, and the parachute did not open. She hit the ground. She crushed her pelvis. She had Harrington rods, crushed her lumbar spine. Came in to see me, looked at the case history, and quite frankly, I was frightened. Called her orthopedic surgeon. Orthopedic surgeon gave me the go-ahead to do the structural integration. This individual, a year after, started doing triathlons and actually started to win. She was in horrific pain. She was failing, and she was having a miserable life with the pain and the metal and the stress. And I was not only shocked, but I was humbled. I was humbled from how powerful the work is and what it can do. And perhaps, just maybe, I wish I had learned the work many, many years before. There's amazing bodies of work and amazing things to learn. It's not just myofascial release. Continue on with your studies. Go down that road. Go down and find your journey. Scott, I'd like to take some questions and answers if you guys are good to go.
We have lots of questions for you, Barry, and we're ready to go.
Not too hard because I'm not that smart, frankly.
Yes, your questions, we're going to make them as difficult as possible. Excellent. Actually, I'm going to turn it over to our friend Eric Brown now.
Hi, Eric. Hello, Barry. Fabulous presentation. I have so many questions here. I hope I can manage them all as they're coming in. We'll see what I can.
And thanks everyone for sending in the questions, because this is how we learn, and I really appreciate everyone taking part of this. It's very humbling, and thank you.
Absolutely. We really do appreciate the questions. Now, I've had a couple people ask, how do you do myofascial release with an obese client?
Surprisingly enough, it's not as difficult as what you would assume. And frankly, it's actually more difficult to do it on somebody who's really, really thin, aka Barry, who weighs about 125 pounds soaking wet. I'm just a bone and tendons. With someone who's a little bit heavier set, what I do is I engage the fascia. In other words, I find that area restriction. I hold on to it, whether it be through fingertips, elbow, and then I have the client move. In other words, they may be moving the pelvis, they may be reaching, they may be breathing into the area. Get the client involved. The biggest client I had was someone with the Montreal Alouettes. The guy weighed 350 pounds. He was a linebacker. His leg weighed more than me. But what I did, I found the area of tension, held onto it, and had that individual help me perform a really successful treatment. It can be done. Just get the client to work with you. And they really like to do it. They really like to be a part of their treatment process and their healing process.
Okay. Now, can a petite therapist use myofascial release? How difficult is it for the small therapist?
One thing that I learned when I first got out as a massage therapist, and once again, for those that do know me out there, I really only weigh like 130-some pounds. I realized that I needed to find some techniques that were going to help me not only perform effective and deep treatments, because I'm a deep therapist, but also not kill me and not cripple me. And I used myofascial release because for me it was what I needed. It was an effective treatment. It was easy on my body. I was taught how to hold my position and my posture properly, and I actually way less hands-on work than the average therapist, because if I can engage that fascia and get that client to help me out, then we can get a really successful treatment. And some of the work by a guy named Aaron Matties, and I hope I pronounced his last name right, isolated stretching, fundamentally just really great work to add on to MFR. But as a small person, there is no problem whatsoever getting a deep treatment and saving your body.
Okay, and we have a question that comes up repeatedly. How would you describe the difference between myofascial release and what would normally be called deep tissue massage? A lot of times the lines get really blurred on what is the technique working on. I can say this. If the technique is using very little or no oil, its purpose is to realign the structure, then it's more than likely on the lines of myofascial release. Other styles of work, for example, if you use a little bit more lotion, oil, lubricant, whatever you like to call it, becomes more of a deep tissue technique. Extremely effective, very, very good work. Does it realign the posture as well? I'm not so sure about that. But that does not underestimate the effectiveness of, say, deep tissue massage therapy for sure. Okay, so not all deep tissue massage is necessarily fascial release.
Not necessarily.
Okay. Someone else, and here's another common question that's coming up here: does myofascial release need to be painful?
No, not at all. Not at all. Really, unfortunately, the work at one time did have a reputation of being excessively heavy-handed, that on a scale of 1 to 10, 10 being very, very painful, that you had to take the client and or patient, and I use those words interchangeably, into a 10, have them withering on the table to get a change physiologically in the fascia, and that is absolutely not true. In fact, we're governed up here in Canada and I'm sure it is throughout the United States as well, because I do teach down there a lot, when the client says it's too much, then it's too much. What I really found interesting is by softening the work and working with the client, you can get as good and, in fact, better changes without having to go through all that pain. And if you're applying excessive manual pressure, I would suspect that it's got to be hurting you as a therapist, too. That seems like a lot of work, and you don't have to do that to get a really great change for the client, and nobody gets hurt. And I think that's the way to do it.
Okay, now there's some more questions about the actual application of the technique. Someone's wondering if you just do a myofascial release treatment, or is this something that can be integrated into a regular massage?
That is a fabulous question. When I'm teaching massage therapists and physios and chiropractors, I say this. Barry Jennings, decided that I was going to do myofascial release. And that's what I do in my clinic. Someone comes in, I use MFR on conditions. Having said that, what I recommend for therapists, students that are taking courses, whether it be mine or anybody's courses, and there's some phenomenal ones out there, use the techniques, learn the MFR techniques, find a tough condition, client that you're just not getting the success that you want, try 2 or 3 of those techniques, and then add in your normal repertoire. I found myofascial release to be a really great marriage with, say, deep tissue massage or Swedish massage and those other techniques. It works extremely well and a really powerful add-on.
Okay, here's some more techniques. Terry is asking, let me see if I can find your question here again. Well, I'll summarize your question because I can't find it in my massive list of questions here. Oh, here we go. Terry from Everly. Is there an area of the body that you would suggest to start with myofascial release, or does it depend on the problem that is going on with the client?
That is a awesome question. Generally, with people taking seminars and taking workshops, what I do is, if a client comes in, go to what I call ground zero. In other words, if they come in with headaches, trigger points, adhesions with, say, the levator scapula, attachments onto the medial superior angle of the scap, go to that area. Try the MFR techniques out, and then once again, use your regular treatments, your regular techniques after. Wonderful marriage. Having said that, what area do I find that can fundamentally change the posture? I would have to say it would be the pelvis. If the pelvis is anteriorly rotated and the person is continuing to have chronic headaches, migraines, postural stuff, the pelvis will help to correct a majority of conditions. And that's why the 10 sessions of posture realignment called structural integration, for some of the advanced training that I do, is so effective. It's one of those like, okay, I've tried everything else, now I'm going to try this. That's an awesome question. I appreciate the question.
Okay, and I just want to say that you have been getting some fabulous praise about your presentation. One person says, Barry, this is one of the best presentations on fascia I've ever heard, very clear and well communicated. Thank you. So we're getting lots of these coming in as well. Now, here's another question related to the actual application of the technique. Does the speed and direction play a major factor in your approach?
Boy, oh boy, we got some pretty smart listeners, and everyone's really into it. And it's exciting for me. Speed is a phenomenal, important part of the technique. I'll be real honest with you. The first couple of years when I practiced, and I was learning some myofascial release, I was a sports therapist. You know, little guy. You know, wanted to be a big guy, big ego, la 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 la. I did the techniques really fast, and quite frankly, I did really terrible work. It wasn't until I smartened up, started doing the technique slowly, I started getting better changes. I started doing less work. And some of the people that taught me, like Michael Shea, kept saying, slow down, and when I did, magic happened. In regards to the direction, man, I'm going to give that to Ida Rolf. You know, she said, put the body in a good anatomical position and then ask for movement. So anytime I'm doing a technique, I'm looking at the posture of the person, even if they're on the table, lining them up, then doing the fascial technique. So I'm really, in my treatment repertoire, when I'm doing the work, I'm really looking at the posture. You know, do I need to do more pillowing here? Do I need to change that? Because if I do the fascia work and the person's in an improper posture, well, I think I'm just kind of like highlighting that. And that's not really what I want to do for that client.
Okay. Micheline Godet says, hi, Barry. And I guess she's taking one of your workshops because she says, think deep, don't go deep. Well, she'll always remember that, Barry.
That it really is quite true. If your intent is to, I want to change or help that psoas because I think it might help that individual, you can actually affect that psoas without having to grind through and tear apart that individual. You really can. And as I become, you know, more and more intelligent in my profession, I really do realize that the people that were telling me this work, you know, those master therapists that were out there, really were onto something. And they weren't trying to baffle you or pretend they were better than you. They were humble therapists, just like, you know, like other people. They were just trying to help. And if you do think deep, you can go deep. And that's and thank you so much for saying that. It does bring back some awesome memories. It's a pleasure.
No, I can't. Again, I can't find it here in all the questions, but with regards to the actual application of the techniques again. Now, are these techniques are held for some time in some cases? Any suggestions in terms of how to sustain that pressure? It's very hard on the therapist.
Okay. I want to go right back to the different styles of fascia work. Two styles. The indirect, and I think this is what this individual is talking about. That's where, say, in a cross hand pattern, you're on the lumbar spine, person's on their stomach, prone, cross pattern, and you're holding and waiting for that to soften and release. I will say that is taxing on the therapist. And the style of work that I find works for me, and I don't want to be prejudiced about this, the style of work that I really like to do, and I seem to be successful most of the time, but not always, is that I would find the area of restriction and I continue to glide and move through that. Very similar to a Swedish technique, except that I'm slowing down. And I honestly did find that after doing 3, 4, 5 hours of MFR, after the treatment day was done, I actually did feel invigorated. Sounds like a sales pitch, and I can understand how people would feel that way, but I really, really did. Once again, some of the techniques that I learned in school, I found really hard on me physically, and I needed to change that, or I simply wasn't going to be able to handle it. There should be no technique that you do that causes you pain day in, day out. Maybe there needs to be a modification on posture or the table height. I had to learn to drop my table down. For those people, and I'm not getting any kickbacks here, my friends, but for those people that have electric lift tables, they are a wonderful invention for massage therapists. They really are.
Okay. Olga asks, can water intake improve fascia? What do you think of that phrase?
I was working with a student at Dalhousie is a big university in Halifax. Mostly lawyers, but hey, let's not go there. She was a student there, and I started working with her, and I mentioned, said, you know what, Sally, I really think that you should increase your water intake. And she did increase it dramatically. So much so, she really didn't need to see me anymore. Now, my friends in marketing were kind of thinking maybe that's not such a good idea. But you really can actually, by increasing hydrating, your water intake begin to help to hydrate the fascia. Kind of makes sense. You know, I am a supporter of some of the sport drinks and stuff like that. The electrolytes, I really like that, albeit you may want to talk to your nutritionist or your MD and make sure that's okay for you in regards to any medical conditions. I find that really helps as well, but Olga's dead on in regards to hydration. It's really important.
Okay. We've also had quite a few questions come in about using myofascial release in a pediatric setting with children. Can we use myofascial release with children, and can you think of any possible indications or contraindications?
Contraindications would be, again, right across the board in regards to massage therapy. If the individual, albeit a child, is not supposed to have any type of manual therapy, then certainly with myofascial release, that indeed does become a CI. I come from a family of, I have like 4 sisters, and I have like 18 nieces and nephews, and I'm a great uncle. Anytime I need children, I go and rent them from one of my family members. I only have pugs, actually, myself. Treating children is amazing, albeit their attention span's really, really low. But you can create some changes, and if you make it fun, if you make the clinic room fun, you can engage that fascia if there is a problem, whether it be from birth or from a fall, because kids like to run around. You can invest into that fascial system, albeit I'm really into going very slow, little change at a time.
Okay. Here's another interesting thing that's come up a couple times in the questions. I'll read one of them from Deborah. Hello, Barry. Do you think using massage cupping is useful in releasing fascia?
I do not have any experience with cupping, which I think goes into, unless I'm getting this totally confused, and I very
this is like the traditional. I'm assuming it's like the traditional Chinese cupping.
Similar to Popement,
like the vacuuming that they do.
I must admit I do not have any experience in that, so I really don't like to say anything if I don't know the work, and it may very well be really effective. Unfortunately, I don't have any clinical experience with that.
Okay. Who is your mentor? Diana's asking, who's your mentor in the study of myofascial release? Are there people who, besides yourself, of course, that you would direct people to for more information? Who's really influenced your thoughts on myofascial release?
Right now in my career, I'm really interested in the Fascia Research Congress and what they're doing. They had a huge thing, and I believe Dr. Schleip was there. They had a huge thing in Harvard. I'm really interested in getting to know that information now in regards to how does the tissue actually change from a histology perspective. I would say Dr. Cantu and Grodin, who are two...
I'm sorry, can you repeat their names again?
Dr. Cantu, C-A-N-T-U, and Grodin, G-R-O-D-I-N.
Okay.
They have a book called, and I'll say it real slow, and once again, if you don't hear it, just go onto my website and fire me off a question. I believe the book is called Myofascial Release in Clinical Applications. And they're physiotherapists, and they're doctor physiotherapists. I believe they're at Miami University, but I might be wrong about that. I really, I read their book years ago, and I really like their information and their research. It's phenomenal. There is so many great people, and they don't have to be famous people. I think there's people in every locale that they have their own experts. They may not have become a big landmark individual, but they do really, really good work, and they've struggled with their maybe with their own bodies and maybe with treating. They've been doing it for years and years. Those are kind of individuals that I think everyone has the ability to seek out and work with.
And I just want to remind listeners that we did have Robert Schleip. Is that how I pronounce his last name?
I believe that's correct.
On our research day doing a presentation. So I'd encourage all listeners to go back and listen to that, because what he did is presented some of the findings of the first International Fascial Research Congress. So definitely check out that presentation. Now, of course, I have lots of questions too regarding training and resources. Can you tell them where you do training, or if they can get DVDs from you, what resources you might have available?
If you go to if you go to my website, Jennings, and that's with one N, Jennings. Everyone says two. If you do punch in tojennings.com, I think you go to to an auto repair place and that. I don't know, maybe they do good techniques, but that's not the body work that I'm doing. There's certainly are resources there. I have a manual that, and it's a manual done by animations, like you saw on some of those slides. And it's really good techniques just to show you how to apply fascia work. And once again, take the manual and begin to make it your own. Adapt it for yourself, your body style, how you like to do the work. What else, Eric? What else did you ask me? I'm sorry.
Just in terms of resources, in terms of DVDs, books, trainings that you do.
I've trained across the United States, and I'm really excited about possibly going over to Europe and some other countries. My courses, they're 95% hands-on. I'll be real honest, I'm not an academic. I leave that to some of the people that spend their life work doing that. I like to work in small groups. I don't like to have 100 people in my clinical seminars. I want to do one-on-one with people. I want to make sure that they walk away and they can feel the work, they can feel the fascia, and they can make a change. So across the United States and particularly into Canada and yeah.
And I'm sure if they go to your website, again, at jennings.com, one N only, they'll be able to find your current workshop schedule.
Exactly, and we're just about to put 2009. The other thing we've done is we put a page on there for if anyone's interested in bringing us out to teach them and work with them. It's called Host a Seminar, and just put your information in there, and we see if we can get something working for you. And once again, we based our company in the 20 years that we've been teaching. The fact that we like small seminars, we like a small group, and we generally bring a couple extra trainers, and I'm always there helping and learning, and I learn from my students as well too. That's how it works.
Okay, so thank you very much. I want to say that we've had quite a few comments from people, I guess past students of yours and people who've just listened to this presentation. They've really enjoyed it, found it really easy to understand, and just wanted to pass that on. Now, I'm going to pass the mic back to Scott.
Well, thank you very much, Eric. And thank you, Barry. Thank you so very much for taking time out of your busy schedule. I know we contacted you. You're in the middle of teaching a seminar. Is that correct?
That's correct. I ran from the seminar room to talk to you guys and everyone out there. And wow, just an honor to be with you guys. It's really quite humbling. And yeah, and thank you.
Well, thank you for sharing your knowledge and expertise with practitioners from around the world. We truly appreciate it.